lines, then it's not going to be scoring. So we have to try and balance our time. What I felt and I realized that what we have to put more pressure on is like using main keywords, which I used to call like keywords, like important information, because you will not be able to, if you see the time constraint with 10 questions, you will have 12 minutes to write one question, and that too also might have two parts. So you'll not get much time to write individual questions. So when you write one question, do not try to elaborate and make it like a very essay based question. I feel what is more important, then just put the important informations. If you can write in a mm, bullet form, or you can write in a tabular form, or you can explain with a flow chart, or you can like put diagrams on it and then explain the diagram. That is going to be time saving and also more scoring, because you're putting all the information but in a very concise way, in a short way. um, and also another important thing is like always look at how many marks this question is for. The same question can come for 4 marks, or the same question come for 6 marks or 10 marks. So write accordingly. Do not write all things you know about one question if it's just for 4 marks, because it's not worth it. And if that same question is for 10 marks or 6 marks, try and elaborate a little bit more. Okay, so I'll give example of how I think one should write and how I have written um, in my exam. So we'll start with this first question where the question was about Lund concept of ICP management with diagram. So be very mindful. The question was about Lund's concept of ICP management. Although, I mean, I have written here Lund concept of ICP with diagram, but the question was Lund concept of ICP management with diagram. So when they're talking about management being the important point, then we'll have to stress on the management. And Lund concept of ICP is a very complicated physiology which we're not using. To be very honest, we're not using it very frequently. It was a concept given very early in 1991. Uh, but so if you want to go into the details of the physiology, it's going to be a long answer, and it's not worth it for a 4 marks. So just keep it simple. First, start with what is the concept of ICP management, and what is the approach. We have to give a little brief first. Even if it's a question on management, you have to give a little brief that what is the Lund therapy of. Somebody's saying there's no audio. Am I audible?
Yeah, you are clearly audible. That is the problem with that person. Go ahead.
Okay. So, Lund therapy is a theoretical approach, as we all know, based on the physiology and pathophysiology and hemodynamic principle. So, what we have to mm, I mean, emphasize here that it is different from the commonest approach we use, that which is a CPP based approach, uh, where we use titrate the CPP to match ICP. So, why is it different? Because we have to write that in a point basis, which I've written. Like it talks about the BBB when it is disrupted after traumatic brain injury. There is transcapillary hydrostatic pressure and colloid osmotic pressure imbalance, which is explained by this image. I have not explained the image here, but it would be important and it would be required that you explain the image, that what you're trying to say here, that there's when there's blood-brain barrier is disrupted, the autoregulation is lost, and then the whole extracapillary filtration depends on the hydrostatic pressure and the colloid osmotic pressure. So basically, yes. So whenever we are dealing with that, a high cerebral perfusion pressure would increase the interest in intracapillary hydrostatic pressure, and that would in turn increase the ICP. So because all the management of Lund concept is based on this. So when you write the principle of management, be very specific and again write in points. So looking at the physiology of it, then we have to talk about what is the difference. Also we have to point in like what is the difference from what we normally is guided by Brain Trauma Foundation, because it is different management. Okay, like so they suggest that we use preserve the osmotic pressure by albumin, but we know Brain Trauma Foundation specifically uh, suggests against albumin in traumatic brain injury, right? So the main purpose, the main management mm, uh, motto here is to increase the osmotic pressure, to decrease the hydrostatic pressure, which we do by using some drugs like metoprolol, clonidine, thiopentone. We decrease the blood pressure, and in turn, that reduces the hydrostatic pressure. And in CBP target also, they target a lower value. Like if the ICP is high, normally we target for a little higher, like 60, 70, not beyond 70 though, but in here, if the ICP is high, we target like a 50, because the same concept, you try to increase the CPP, you increase the hydrostatic pressure. So these things are very important that you point out. Then vasoactive use here, we normally try and keep like cerebral blood pressure augmentation if you want to increase this CPP, but here they actually go the opposite way. You do not want cerebral vasodilation to avoid increase in the pressure and avoid even vasoconstricture because it hampers with the cerebral microcirculation. You talk about microcirculation because the blood-brain barrier is all lost. And also, very, very important that normally we talk about 30 degree to 45-degree head elevation, but they say they want flat head position. They use the sedation, but other things that we use like neuromuscular blockade, hyperventilation, osmotherapy, and barbiturate coma, these are all avoided because they also increase this transcapillary filtration. So these are the very important points because these are very different from what we normally do. But write in a point manner so that you save time and you put all the important information. Okay. Okay, so this is something just I added because I thought it um, for everything. When you talk about management, you have to talk about what is the evidence, what is the guideline say. So Brain Trauma Foundation does not support use of Lund approach because it has not been supported and has not shown much good outcome in multiple meta-analytic and systemic reviews. But obviously there are some different, you might come across like a study which says that it has potential, but do not go into that much of complications. Follow a guideline. If the guideline says that this is not what we are using, then this is not what you're using. I've put in some suggested reading. I'm not sure if these slides will be shared with you, but I have added suggested readings like some articles and studies which I have read this topic from. So if you guys,
Sangeeta, just we have to go a little faster
okay.
because we have to finish 5 questions till 2 o'clock, till in next 20 minutes.
Oh,
Yeah,
okay, fine.
you
Sorry. Okay.
should be written for this question. Yeah.
Okay, fine. Okay. Next would be modalities to reduce ICP. This is a very straightforward question. I don't think anybody would have much confusion regarding this. What we follow is like tire-wise management. So definitely, please write that way. So it will be simple. Tire 0, ABC, how you manage blood pressure, CPP, fluids, be very specific about putting what drugs we use, what drugs we do not use, which fluids we use, which fluids we do not use. And then sedation, what does it do? Just keep it brief. Do not have to put why sedation is required, but we need to put sedation because it decreases CMR2 and CVF in turn. And then cerebral venous drainage, what do we do to maintain that? Fever control and glucocorticoids, and which subgroup we use. Then tier 1, which is specific therapy, osmotherapy, commonly used drugs, their doses. Is there any one superior than the other? If yes, then why? Maybe these points would be very important. Then tier 2 has two interventions. It could be surgical, it could be non-surgical. What are the surgical options? And in surgical options, decompressive craniectomy, you can mention the studies that we have in TBI or in increased ICP in malignant MCA for decompressive craniectomy if you have time. You can just mention the names if you do not get time. At least that'll put an impression that you know or you didn't miss it. And then no, non-surgical would be hyperventilation and anti-seizure therapy. And just like one line each, it would be, I think, good enough. Then tier 3 therapy is for refractory cases where we use barbiturate coma and therapeutic hypothermia. But then, as we know, that therapeutic hypothermia still not into as like an evidence-based practice. So just put one line and what's the study behind it. Okay, I have put in a flow chart like how to manage ICP when you're coming across a patient of TBR with severe ICP, but you do not have to put it unless that's how the question is framed or that's how you want to write. Like if it's a clinical question and comes on how you want to manage it, maybe put a flow chart. It's just for an example that how you can write an answer. Okay, if they say enumerate, then do not write this way. If they say how will you manage, maybe this way. Okay, again some references. Okay, we've moved to our next question. That would be enumerate causes of ALF in India for 4 marks. It's again a very straightforward question. The common causes, and make sure you read the word that they say it's India. So do not write paracetamol as the first cause of ALF. So hepatitis, and then in drugs, even in drugs, paracetamol is very uncommon. So just keep it in mind. You read the question. If it is enumerate the cause of ALF, it will be different because it's in India. It's different. So drugs, ATDs, make sure you do not miss the important ones like ATDs and CAMPs. Even if you meet antibiotics, it's not a problem, but you cannot miss ADDs and alternative medicines. Poisoning, miscellaneous, and also keep it in mind that in tropical fevers that we get in India, they create a ALF mimic kind of condition. They are not ALF. So you mention that they're ALF mimics, but it is important to mention that. Various criteria for liver transplant. uh, these are some names, just put the names, but mainly I think two things you have to speak about here. It would be for acute, we use King's College criteria, so paracetamol uh, related and non-paracetamol related. This is a very straightforward part of the question. And then for chronic or acute also, we use MELD. So maybe write a little bit on the details of it with MELD because it's a question for 6 marks. So how MELD came into play, what is the main score? If you can remember, that will be great. What is the scoring pattern, like from 6 to 40? And then how patients are put on a waiting list based on MELD. And there have been multiple MELD modifications right now. MELD sodium, MELD 3, why they came into play, why MELD sodium is now being used, why MELD 3 is being used now. Even if you can't remember this formula of MELD sodium, I think that should be okay. But try to remember the formula for MELD, the main one. And then important thing would be to remember the MELD exceptions. So when you write about transplant criteria and you write about MELD, it's also important to write about what the conditions where MELD is. There is MELD exceptions, and they give like a lower score, okay, or a higher score. Yeah. So the third question is they said enumerate discuss 5 dyssynchronies in a spontaneously breathing patient in invasive mechanical ventilation. Again, this is a very good scoring, uh, simple, straightforward question. So just write what are the types of asynchrony first, and then try and pick up what are the kind of asynchronies we would see in a spontaneously breathing patient, like ineffective double triggering, premature cycling, delayed cycling, insufficient flow, excessive flow. These will be there, right? Reverse also. But auto triggering is not related to whether the patient is spontaneously breathing. So probably just not mention that one. Just pick any 5, whichever you are comfortable in, whichever you understand better, whichever you're comfortable with making the diagram. And what are the things you're going to write? See, it's five dyssynchronies they've asked for, and you've got 10 minutes. Sorry, you've got 10 marks. So just imagine like 2 marks for each one. So it's not that you have to write a lot. Maybe make it like a table format, how I would do it. Like write put one ventilator synchrony, pick up, and then write what is the determining factors, like why it happens, some ventilator related cause, and then some patient related cause, and then how would you manage it for patient and for ventilator. So I think this would be the approach you go for every one of it. Like put ineffective triggering, why is it causing because of ventilator, for patient management, and put the image. Okay, so I have like placed it in that format. Yes, pick any five you want and then write their causes, and then definitely bring the images and point it where you seeing their synchrony. And I think that would be very easy to score kind of a question. Okay. The fourth question would be the discuss literature supporting the use of balanced crystalloids in ICU. This one I feel little possibly less scoring for some people. I mean, I find remembering the uh, literature details of literature very difficult. But it's a question for 10 marks. That's why it is very difficult to understand how much you can write. So maybe just first put forward the names of the commonest fluid trials which support colloid, crystalloid, balanced crystalloids, and um, balanced crystalloids and saline. They have not seen any difference. And then you can, like, there are two suggestions that I'm going to give. You can either go one by one, write a little bit about the fluid trials that has come over the years and which has had seen any benefit at all with balanced crystalloids. Like when you write about it, you this UNOS one and the SALT one and the SMART one, they had some benefit. Like UNOS had a significant AKI reduction, and SALT and SMART also had some reduction in their um, renal and make 30 secondary outcome. So either you can go that way, or you can put like a chart or a table like this, okay, where you write where was it done, how many patients, what was the setting, what were the main patient population. If you remember how much you remember, it all depends on that, okay. And what was the fluid used, and how much fluid, what was the primary outcome, what was the secondary outcome, where they found the benefits, where they didn't find the benefits. And if you remember key limitations, you can write maybe one or two. And after you write for this particular question, if you encounter this, after you write the individual trials, also remember if there is any significant important meta-analysis or systemic review has been published recently, you have to write about that. For this particular topic, there is recently two meta-analysis and systemic review have come up. One is in 2022 in NEJM evidence, which kind of says that there's a high probability that balanced salt solutions reduce mortality among critically ill patients. And again, a very important one, which is published in 2024 in Lancet, which is called Best Living. I'm sure you guys have heard of it, which is again also found that I balanced crystalloids reduce the mortality risk. So uh, if you can write briefly about those meta-analysis also, like how many studies they uh, did the meta-analysis on, and what was their primary outcome, what was their secondary outcome, and which one was the part that they got any significant um, findings, which or and which one was not very significant. Okay. So this best living one was probably the most important one because the recent one and includes all the articles. And they also in their primary outcome was in hospitality mortality, and secondary outcome was individual organ function. And they also found that there's a high probability that they reduce treatment with renal replacement therapy and decrease in hospital risk of death. So this is very important. When they ask in favor of balanced crystalloids, you have to put this. Now the final question, again, this is a very straightforward and very scoring question that you have like so much to write. The first question is physiological changes in pregnancy in third trimester, airway, respiratory, cardiovascular. So go one system after the other. First airway, then respiratory. You can either write it like points like chest, diaphragm, volume, diffusing capacity, ventilation, however you feel comfortable, or you can make like a table like this. This is something I've picked up from Miller, which is I think is very good. Absolutely up to you if you want to like make a table, put the parameters and what happens when you reach term, how much percentage wise increase. If you can't remember how much percentage wise it increase, maybe just write in words like paragraphs. But make sure you put all the points. It's not about how much you write in each point, but you have to address all the points like minute ventilation, tidal volume, lung capacity, diffusing capacity. What are the things that don't change? That is also important. You have to mention, you have to remember to write it like FEV1, closing capacity. These things don't change. So make sure you write them as well. Same for the cardiovascular system, go point wise, like what happens to plasma volume, heart rate, CVP, SVR. Not a lot of in not a lot of study material when you read about this mention about these two things like uteroplacental circulation and other vascular changes. But try and find out wherever you get it, like how much uterine artery flow is increased and what happens to cerebral blood flow, why there's more chances of bleeding, and why aortic dissection is also very common in pregnancy because that flow is also increased. So please, wherever you read it from, please make sure you go through these two and make them a part of your answer. Again, you can write in this table form. And then the question was management of peripartum cardiomyopathy. It was for 4 marks, but I felt that there's a lot to write. It's very difficult to write it in 4 marks. But the same question you can get in your exam for 6 marks. So exactly like I said in the beginning, either concise if you have it for 4 marks. If it's for 6 marks, you can write it a little bit more. But how you write it is basically just give an idea what is a peripartum cardiomyopathy, what are the general goal of treatment, then with oxygen and normal, how you manage a heart failure, like symptomatic management, talk about it. Then how do you manage the sequelae? What are the commonest sequelae like cardiogenic shock, arrhythmia? What are the things you can use? What are the things you cannot use? Like it is very important to mention that amiodarone is avoided in first trimester and the drug of choice there is flecainide when you have a atrial fibrillation. And if you can use DC cardioversion or not, yes, you can. And how to place the pads. These are the tricky things that should be mentioned. Okay. And then when you're talking about peripartum, anything peripartum and their management, so obviously you have to mention about how do you proceed for the delivery. Do we deliver immediately or we don't? When we deliver, when we do not deliver, if the patient's stable, unstable, and then we can, if the patient's having like the treatment, there are a lot of things that would be excreted with breastfeeding. So can the patient breastfeed? So that's also important. And there's some investigational therapy, like some immunosuppressive therapy. This is a part where you can cut down if you have less marks and you have less time. But if you have more time, maybe just write what are the investigational therapy that is now being used, now coming into the market. People are working on it, trials going on, etc. And then if you have time, then long-term management, because peripartum cardiomyopathy can uh, continue for a few more months, and it's very important to know how we wean it, and if we how we wean the medications if the patient is improving, and if we can't wean, what do we do? So there is a weaning protocol for it, like which drugs we started and how do we stop it. So one by one, but again, this part cut short. If you have for 4 marks, if you have for 6 marks, you can maybe build up on it. Okay. And yes, I think that'll be all, and good luck to all the candidates. I hope it was useful.
Yeah. Thank you, Sangeeta. Thank you very much for your excellent presentation. From my point,
Excuse
yes.
Good morning, everyone. I'm sure Dr. Sangeeta has covered a lot about approach to the answering in DNB. Let's go into specifics. We'll be discussing more on it when we go into the questions. So this is Dr. Nishant. I'm a consultant in critical care Yashoda Hospitals, Hyderabad. So let's go to the questions which were given to me. These the first one is enumerate the pre-endoscopic management steps.
Nishant, your screen is not only first slide is visible.
I'm just reading out the questions first, sir.
Okay, fine, fine.
Just to play if it is changing.
Yeah, it's running well. Okay, move ahead.
So the first question contains two parts. The first one is enumerate the pre-endoscopic management steps in a patient with significant upper GI bleed. The second one is stress ulcer prophylaxis in the ICU. Discuss the literature supporting or refuting its routine use in critically ill patient. The second one is discuss the management of poisonous snake bite in India. The third one is describe hemoglobin oxygen dissociation curve and discuss the management of dapsone induced methemoglobinemia. The next one is describe reporting of serious adverse event in ICU and post event systematic audit process in a case of accidental or inadvertent expulsion of tracheostomy tube in a ventilated patient. And the last one is discuss diagnosis and management of C. diff infection in a patient who is admitted in the ICU with foul smelling bloody diarrhea and hypotension. So let's get into the answers. The first one. So if we see this question, it was they asked for a pre-endoscopic management in a patient with significant upper GI bleed. So as critical care physicians, if we see the difference which we can make before endoscopy happens is obviously the airway breathing circulation, because they have mentioned a significant upper GI bleed. Obviously we'll have